Hello and welcome to the On the Couch podcast, the podcast that gives you the view from the therapist chair. I'm your host, John Dennis, a licensed professional counselor. You're listening to OTC episode 51 with Sheri Van Dijk, author of Don't Let Your Emotions Run Your Life for Teens. Welcome back, OTC listeners. Thanks for stopping by. Wow, man, we are flying through 2020. We're almost to the election. I think we're, like 2 weeks out, something like that. I think everybody's just under unbelievable amounts of stress and strain with everything that's going on in our world with, school and work and finances and COVID and election. And it's a lot. And so I wanted to share this interview that I did, this conversation with Sheri Van Dijk, who you hear me talk in the episode about it, but she's the author of a number of books, but the specific one that I'm talking with her about is Don't Let Your Emotions Run Your Life for Teens. It's a DBT workbook, so the dialectical behavioral therapy that you hear us mention a lot on this show. I think obviously everyone is struggling emotionally and mentally and physically and spiritually, politically, financially, every E you can struggle with. But for teens, this has been such a difficult time where navigating having to be remote option or homeschooled or in person and maybe not being able to see friends or not have access to extracurricular activities the way that we used to. Some school districts are still doing, sports seasons, but they're really modified. They're not doing out of conference or tournaments that go out of state or things like that. So just so many things that our teens are having to navigate in addition to, oh yeah, by the way, all of the normal stress that you go through as a teen, surprise, we're just going to, lump all this other stuff on. And so it's been a challenge for parents and school administration and school counselors, obviously a lot of other people beyond just those few that I named just now. But yeah, it's been really difficult. And so the skills that Sheri teaches and helps to instill with the DBT skills and, kind of talking about, okay, what is a full DBT program and some of the skills in the workbook and other resources that she uses can be very, very valuable. I mean, beyond teens struggling with emotional regulation and maybe self-injurious behaviors or suicidal thoughts or things like that. It really, like I say in the interview, I mean, the DBT skills really can be useful for all of us. We would all benefit from it. So I hope, as always, that you take something from this and that it benefits either you or somebody that you know and love. Sheri Van Dijk is a well-known mental health professional. She has advanced degrees from York University and the University of Toronto. She's got over 15 years experience as a psychotherapist and an international speaker. She's written a number of books, including Calming the Emotional Storm and Don't Let Your Emotions Run Your Life for Teens, which we talk about in this episode, as well as a ton of articles. She regularly, conducts training sessions for fellow professionals in the field. And she's got extensive experience and knowledge of dialectical behavioral therapy, cognitive behavioral therapy, and mindfulness practice. She has 14 years of experience working in an outpatient mental health clinic at South Lake Regional Health Center and now works full-time at her private practice up in Newmarket, Ontario. All right, so I have on the show today Sheri Van Dijk, who's a registered social worker up in Canada, and she is author of the workbook "Don't Let Your Emotions Run Your Life" for teens, and you've done so much in the space of DBT and working with older teens and adults. So thank you so much for being on the show.
Yeah, thanks for having me, John. It's great to be here.
Yeah, I was really excited when we were able to put this together. Like I mentioned, I've known about your work for some time, and I refer to your book and recommend parents and adults pick it up. Probably more than I would like to recommend it, but so yeah, how did you even get into counseling and get into working with DBT?
So it took me a while actually to kind of find my path just in terms of psychotherapy. I think probably it started off, I actually had a car accident when I was pretty young. I was about 17 and I had a pretty life-altering car accident. I was very lucky. And I didn't realize at the time, but I think that's kind of where my interest in mental health started, because I did have some, now looking back, had some, post-traumatic stress responses after that.
Wow. Okay.
And started around that time as well. I was working as a pharmacy technician in a pharmacy, so started having interactions regularly with customers who would have mental health problems. So I think that's probably where my interest stemmed from. But then as time went on, I, was doing a degree in university, didn't know what I wanted to do with my life, and kind of fumbled around for a few years, as I think many people do nowadays, not knowing, what direction to go in. And accidentally, at one point, found myself working as an administration person, basically a secretary at a community mental health agency.
Okay.
And that was really where I found my groove. I thought, oh my God, this is exactly what I want to be doing. So there were MSWs, social workers in the office who were doing psychotherapy with people with severe mental health problems. And it was just like, epiphany. So I started the process of going back to school and was able to work at this fantastic job and learn kind of on the job as I was doing my first bachelor in social work and then a master's degree in social work.
Awesome. Wow.
So that's how I came to psychotherapy. And again, kind of the universe steered me in the direction of DBT, where I was doing my MSW placement at a community hospital, where they were just getting involved in the startup of a community DBT program with some community partners. And so I basically, from the beginning of my career, started learning about DBT at that point, and it just, sort of spiraled from there. And spiraled in a good way, of course.
Well, yeah, I was going to say, did you see that as like, wow, this is, like you said, my groove, like I found it. I really enjoy working with DBT, or was it more like reluctant, where it was like, okay, I keep getting drawn to this? And
no, it wasn't reluctant at all. Actually, I had been primarily in a CBT environment before that. And so, of course, was just kind of going along with that CBT flow that I had been subjected to. Again, not in a bad way, as I'm saying this. It's just a very positive experience. But as I was in this CBT-oriented agency, that was just kind of what I was doing, because that's what everybody else was doing. And then once I started learning more about DBT, it was just like, that's where, again, the light bulb went on for me. It just made so much more sense for me than the CBT. CBT, I was okay with, it made sense. I was using that to work with people. But then DBT was just like profound for me. So yes. And, using DBT, not just in my work with clients, but in my own personal life. And I share this regularly with people, about how helpful the skills are, I think, just for all of us. We all have, look at what's happening in the world right now. You and I were chatting just before the podcast started. the stressors that we encounter on a daily basis, sometimes more than others, we all need skills like this just to help us manage emotions more effectively at times. So it just made more sense to me in terms of generally working with clients, but also dealing with my own stuff at times.
Definitely. Well, and to kind of, for listeners that may not know, so CBT typically referring to cognitive behavioral therapy, the DBT more so the dialectical behavioral therapy. And yeah, especially the time frame that we're talking about, I would say most everybody was in that, CBT kind of model or focus. And obviously, DBT and mindfulness has gotten a lot more traction in the last, I would say, 10, 15 years, something like that, maybe even more. When you're referencing that, can you kind of just give the Cliff's Notes version of DBT?
The Cliff's Notes version of the origins of DBT?
More so just the concept, the philosophy, the tenets of it. Sort of the overview. I know we could probably take do an entire podcast just on that.
Cliff's Notes. But no, we'll do the Cliff's Notes. So first off, I find it interesting because often people will contact me and they'll say my doctor referred me for CBT. And so my first response to that is, well, DBT is a type of CBT, and this is something that people often don't recognize. That actually, so just to quickly do the origins part, DBT started out as Marsha Linehan, who's the creator of DBT. She started working with her team to address the needs of highly suicidal individuals who being at high risk. They started working with this population from a CBT model. And we're really finding that CBT wasn't very effective for that population that they were trying to help. So this is where DBT came from. And so DBT is a type of CBT. When I'm describing this to clients, though, because they'll often ask me, well, what's the difference then between DBT and CBT? My Cliff's Notes version of that is DBT is CBT on steroids, is how I like to put it. Of course, it's much more than that, of course. But when I'm especially talking to a client, what they need to know is that DBT is kind of the pumped up, newer, improved version of CBT. And of course, I completely admit that I am very biased about that, but that's how I see it. So DBT so it's CBT oriented, but it also draws on a lot of other different therapies as well. And so often people will find similarities between treatments that they've done, with other therapists or whatever. Sometimes the language is very familiar. Mindfulness, for example, nowadays, most clients come to me with at least a basic understanding of mindfulness. So DBT, though, kind of pulls together all of these different strategies and techniques and is much more, I would say, palatable for most people in that it's not just all about pushing clients to make changes, which can, for some people, be very invalidating and feel intolerable. Mm-hmm. So it's about finding more of a balance to help people accept who they are and where they're at in their lives, and then help them find ways to make changes in those areas that are keeping them unhappy. Yeah,
the idea that it's sort of the next step in the progression, that taking some of those concepts from CBT, and like you said, a lot of people finding that CBT was not a one size fits all. It doesn't work that way, and people were finding, okay, we need something else, something more, and I think especially the balance of your thoughts and your emotions, and in that mindfulness, the wise mind kind of, okay, you don't have to do anything with it. You just connect with it, focus on it, move into it. And I think definitely the CBT, I guess I find so many people, that's what they wanted to do, is like, I don't want to feel this. I don't want to think about this. I want to shut it down and shift it. Would you agree with that?
Definitely.
Okay.
Yeah. I mean, even people who come in and I'm doing work with a young woman right now, for example. We've been working together for about 1.5 years, and she has, lots of complex post-traumatic stress disorder symptoms and depression and anxiety. And so even working together for 1.5 years and knowing that she was coming to me for DBT and knowing a little bit about what DBT is, still we're struggling with her being able to sit with and tolerate emotions instead of having to get rid of them or do something to change them right away. Mm-hmm. So, yeah, and I think it's a human nature thing, right? We don't want to suffer, but what we often don't realize is that by trying to not have the experience, we're actually often increasing the suffering.
Yeah, prolonging it, definitely.
Exactly.
Yeah. And in terms of, your experience, the concept of, emotional dysregulation, obviously the DMDD diagnosis has become very popular as well. Do you think emotional dysregulation, is that just part of the human condition as well?
I mean, yeah, I think so to an extent. I would say for most people, of course. Although even, if you think about the people who tend to, stuff emotions more, I think of them as the more reasoning-minded folks. Even that could be seen as emotion dysregulation, where there's that, automatic avoidance and denial and, that kind of thing, pushing away of the emotion. So even that could be seen, I think, sometimes as emotion dysregulation. But yeah, approximately 85% of the diagnoses in the DSM-5 involve emotion dysregulation of some sort. So when you think about, people with depression, with anxiety, with bipolar disorder, is, the epitome of emotion dysregulation with the ups and downs and everything. And then, of course, we think about people who don't have a diagnosis. I spoke earlier about my own experiences. Mm-hmm. There are times, where I might fly off the handle when my dogs get into something in the house, and I'm able now, using skills, to put more of a cap on that and not just react the way I might have before. So we all have experiences at times. Think about grief is another good example, where I remember being at an uncle's funeral. I lost an uncle when he was 41 years old to a brain tumor. I remember just sitting at the memorial service for him, and just the overwhelming emotion and just the sobbing I could not control. Like, we all have times where we are just out of control with emotions, or at least we feel as though we're out of control with emotions.
And the DMDD side of things, obviously, sort of the clinically significant in, air quotes, of disruptive mood dysregulation disorder. Sure. As the DSM-5 came out and kind of looking at the landscape of, gosh, there's a lot of overdiagnosis of bipolar disorder and childhood bipolar, which weren't even supposed to be able to do, really. Right. A lot of misdiagnosis, I guess I would say. DMDD grew out of recognizing the need for that diagnosis to kind of shift that trend, I guess I would say. And for you, when somebody first comes in, what are some of the things you're trying to focus on, trying to teach or work on?
Mm-hmm. So for me, first off, you're talking about the DMDD diagnoses and those kinds of things. For the most part, I don't get so focused on the diagnoses.
Yes. Thank you.
Yeah, no, that's okay. I just like to put it out there. First off, because I'm a social worker, so I don't diagnose. In Ontario, we can't diagnose. Mm-hmm. And I actually like that because for some people, they find the diagnosis very helpful. And so if that's the case, by all means, I help them get it, or we talk about what the diagnosis is or whatever. I don't want to invalidate that if that's their experience. But for me, the diagnosis isn't important. What's important is looking at how is this constellation of symptoms affecting this client and what are they identifying as the problem. Yeah. And then that's what I'm helping them to work on.
To pause there for just a second, I'm so glad you brought that up because, I get, we needed the DSM, we needed the criteria and the terms to be able to all kind of work off of the same framework, and of course with managed healthcare. But yeah, a lot of times I say, look, you can call it whatever you want, but these are the symptoms that you seem to be dealing with, so let's figure that out. I think one of the soapboxes I get on a lot of times is just how trivialized the language gets, and how everything gets psychopathologized, where it's, any bad thing happens, you have PTSD, any show of anger and you have bipolar, or, things like that.
And I love the way you put that. No, I'll do the same thing with my clients. I'll say, you know what, especially so the clients who don't like the diagnosis or who don't want the diagnosis perhaps that they've been given, I'll say, you know what, we don't have to call this bipolar disorder. We can call this Sheri syndrome. Like, know what these symptoms are. Yeah. You have been living this experience. It doesn't matter what the label is that we put on it, right? Yeah. We're still dealing with the same thing. Mm-hmm. And so then that's what I help them look at is what are the problems that you're dealing with. DBT is a very, we focus on the skills deficits. So what are the skills that this person is lacking that I need to teach them? So that's what the assessment is about, is where are they lacking skills? And then that's what I'm going to be helping them to learn. Mm-hmm. And usually these are skills, emotion regulation skills that most people learn in their, early environment, growing up in their childhood and their family of origin stuff. But sometimes the learning doesn't happen. Sometimes the teaching doesn't happen because, there's other stuff going on in the environment and there isn't enough energy and focus to go towards the teaching. So an example would be, if you have a parent with a mental health problem and they're in and out of hospital, right? It's really difficult for that environment to be there and to give the child, especially if it's a child with more emotional needs than an average child. It's hard to meet those needs and do the teaching that's necessary and required for that kid to learn, how to manage their emotions in healthy and effective ways.
Yes. Yeah. And I think of, families and households where either the emotion is like shut down and sort of stamped out, or there's so much emotional dysregulation in the family system that's modeled and taught.
Exactly.
And are there, in the work that you've been doing, are there trends that you're seeing in the landscape in terms of emotional dysregulation and DBT and anything that you can share?
Well, I think one trend actually that just pops automatically into my head is the amount of people who are becoming more and more familiar with DBT and who are looking for it. Yeah. And unfortunately, in Ontario, at least in the area that I am, we don't have a lot of DBT programs or DBT-informed therapists. Okay. So I think that's one difficulty. Other trends, though, just in terms of emotional difficulties people are experiencing. I think because emotion dysregulation is so broad, and because I look at it through that lens, I don't really see, trends in that way. Like everything I see it as emotion dysregulation. Uh-huh. Right? So, you come in with a diagnosis of depression. Okay, well, that to me is a
emotional dysregulation. Yeah. How
is that affecting you, right?
Well, it almost made me think of, the autism spectrum. We talk so much about, that's such a vast thing. It's almost this like, what does that even mean?
Yeah, exactly.
But I would say a positive in the one that you started off with of people becoming more educated and more aware of it and the need for it. So that's a positive. Obviously, not great that there's not a lot of resources in terms of DBT trained therapists or programs that have that focus.
Right. And actually, as we're talking about that, John, can I actually back up and describe for people what a DBT program is? Because I think this
definitely.
is another part that, people often don't actually realize, and even referrers, when they're sending people to me, I'll get a call from somebody saying, oh, my psychiatrist wants me to have DBT. So the first thing that I like to educate people on is what that means exactly, because I don't actually provide DBT, is what I tell people. So I provide DBT informed therapy, or I might say that I provide DBT skills teaching in group or in individual. But a full DBT program actually would involve somebody attending individual psychotherapy once a week with a DBT therapist, as well as attending group at the same time. So they do once a week group, they do once a week individual therapy. They also have access to skills coaching outside of sessions with their therapist. Ideally, actually 24 hours a day, 7 days a week, although of course that's not always possible.
Sure.
And that basically helps people to generalize the skills that they're learning, because these skills can be really difficult, first of all, to learn, but then to actually generalize to other areas of their lives, especially when they're in the middle of a crisis. That's the hardest time to bring skills to bear in a situation, when the skills are new.
Definitely.
And then the last part to the DBT model is that the DBT therapists themselves are part of a consultation team that they attend once weekly, which basically helps them stay on track and effective and reduces burnout for DBT therapists with the clients that they're working with. So that is the complete model. And it is important. A lot of people don't need the complete DBT model.
Yeah, the full package, so to speak.
Yeah, exactly. This was developed specifically for that high-risk population that I mentioned earlier that Marsha Linehan and her team started working with. But, in my work, most of my clients don't need a full DBT model, so I provide bits and pieces of the model for them. But I just think it's really important that we educate people on what we are providing versus the full treatment model if we're not part of a program.
Sure. And I think that's also somewhat of a pet peeve of mine, at least. I don't know if you would echo that, of some of that language getting thrown around too, yes. Especially with the whole trauma-focused, trauma-informed, a lot of agencies or a lot all would just, we're trauma-informed. And yes. Yeah, all of us are kind of. I mean, we all went through the grad program or the doctorate. We understand trauma, but there's a difference. With what you were saying there in terms of the more, I guess I would say the more acute end of the spectrum, I know we're saying, okay, we don't want to put everything into a diagnosis box, but can you are there certain diagnoses that typically need the full package, so to speak? Sure,
yeah. I mean, obviously people, the population, the diagnosis that this was meant to work with is borderline personality disorder, right? Mm-hmm. And so, but even then, I mean, I see clients with BPD. I work with clients with BPD who don't have to necessarily access a full DBT program. And sometimes they do very well. Mm-hmm. But I think the way I look at it is kind of the higher the risk, the more service the individual likely is going to need, right? Mm-hmm. So when I have somebody who has a diagnosis of BPD, or even maybe doesn't have the diagnosis, but we're just seeing, they've got suicidal thoughts on a regular basis. Maybe they do engage in self-harming behaviors. There's, an unpredictability and maybe impulsivity to them where they can't commit to keeping themselves safe, for example. Mm-hmm. That's the kind of person that I would be saying, I'll keep working with you, and let's get your name put on a waiting list for a DBT program.
Okay.
Because I see that people really do much better with that intense treatment model. And it is a very lengthy treatment model. So DBT typically is meant to be, if you're looking at a full DBT program, it's usually a year-long treatment. Mm-hmm. People, though, obviously, when they're not, I could have a client who has a diagnosis of borderline, and yet maybe they're not high risk. Maybe, they have some impulsivity stuff, but they don't self-harm. So when I'm less concerned about their safety in that way, then we might say, there's probably no need for you to have that intensive program, and we can do the work here just in group and in individual, or either or whatever. Mm-hmm. So I like to be flexible. I like to be dialectical about it, essentially, right? It doesn't have to be black and white.
Yes. And when you're saying year long, I mean, we're talking outpatient, like maybe a partial hospitalization, or...
So a typical DBT program is just outpatient.
Yeah.
Although there are modifications, of course, nowadays where, partial hospital day programs and so on, even inpatient programs. But the year-long program would be an outpatient program. That would be the full DBT 1 year model.
Okay. Yeah, I just wanted to clarify that in case people were like, what? There's no way I can do 1 year of inpatient.
Yeah. But even as an outpatient, it's very intensive, right?
Oh, yeah.
Like the training group is 2.5 hours that you're doing every week, individual therapy for an hour every single week. So it is a big commitment for people.
Definitely. And I've also found, again, we were saying, very vast spectrum. Everybody can benefit from DBT and the concepts. But in terms of the higher end of the spectrum, like you mentioned, the borderline personality disorder, I would say the bipolar, major depression with psychotic features or not psychotic features, or I don't know if you would weigh in on that.
And so I can't really speak to it from a DBT full, like a traditional model perspective. I can just speak to it from my own perspective. There isn't a lot of research that I've seen so far on using DBT with psychosis. Although I know it is being done, and I know of somebody who was looking at proposing a book on using CBT for psychosis.
Okay.
So it's not happening. I just don't know a whole lot about it because it's not the population that I work with. Mm-hmm. And I would also add to that because I do often get this question from people, and especially in workshops and trainings with other therapists, where they want to know is DBT being used for psychosis. The other part that I'll add is that acceptance and commitment therapy, which is very similar to DBT, I find, not in the program sense, but just in the skill sense. So acceptance and commitment therapy is a treatment that is used to treat psychosis. And so because of the similarities, I don't see why we wouldn't use DBT to treat psychosis. Mm-hmm. I do work occasionally, so especially I do a lot of work with clients with bipolar disorder. And so occasionally I do have a client who is either in, a kind of, I'll say this is not diagnostic, a sort of psychotic episode.
Quasi.
Yes, exactly. Where it's like, for example, they'll be having visual hallucinations, so seeing things that aren't actually there, but they know that those things aren't actually there, right? Mm-hmm. So they're kind of partly in touch with reality. Yeah. And so using skills to help them to, just be mindful to their experience, to be accepting of that experience. The feedback that I get is that the DBT skills that we look at to help with those symptoms are often very, I want to say comforting. Like it helps them to be more accepting and less anxious about what's happening. So they're not as afraid of the experience. Okay. So those experiences that I have had, the skills are still very helpful.
And do you work with PTSD a fair amount as well? I would imagine, and just the populations we're talking about, it's sort of obligatory.
Yeah, PTSD and complex post-traumatic stress disorder, I would say even more than just PTSD. Mm-hmm. Yeah.
Okay.
Yeah, and if you're kind of asking, is it, of course, I think of BPD as complex post-traumatic stress disorder for the most part, right? Yeah,
so, when you really get down to brass tacks, I would say.
Exactly. Yeah, so of course, DBT, for me, that's a no-brainer. It's going to be helpful for people with that, with a trauma history in terms of single episode history. Yes, I think it could still be helpful. And, other therapies, of course, like DBT, like any therapy, it's not the panacea. It's not the be-all and end-all for everybody. Mm-hmm. There's probably more appropriate treatments like EMDR and, CBT for trauma kinds of therapies that are going to be more appropriate for a single event trauma. But when it comes to complex PTSD, I think DBT is a superior treatment. Okay. And there also is a modification of DBT, which is DBT prolonged exposure, or DBT PE, which is also being used specifically for people with that lengthy trauma history.
Now, in the term that you're using there, I almost get it almost sounded to me like exposure response prevention, kind of, where are you trying to get them to connect with the the emotions and the triggers for a prolonged amount of time to help kind of shave down that barrier?
Yeah. No, are you asking about the PE model?
Yeah. I wasn't familiar with that.
I haven't actually been trained in PE, unfortunately. Okay. There's not a lot of availability of training up here in Canada yet, so I haven't been fortunate enough yet to do that. But just from a general perspective with DBT, because it's a CBT because it is based in CBT, we still do the exposure stuff as well. So, when I do have a client, for example, who has social anxiety, I've got somebody I'm working with right now, and we're working on doing some gradual exposure with her to those things. So, there is that exposure component in DBT. We would still do some of those same things that CBT would use, but in DBT PE, the prolonged exposure, it is, it's above and beyond that, I believe, but I can't really speak much more to that.
Mm-hmm. Are there particular diagnoses that you would say, like, it just really doesn't lend itself well? I guess I was thinking more on, like, autism spectrum end of things, or, I don't know.
Well, it's interesting that you say that. So I don't work with autism. I have had some experiences with working with that population, but that requires, another level of expertise in terms of modifying skills and that kind of thing. So I don't do it myself, but there are modifications of DBT that were developed. So Julie Brown actually is an author who modified DBT to work with autism spectrum and intellectually delayed individuals.
Wow, okay.
DBT is also being used with children as young as 5. Mm-hmm. So there are modifications for that. And there are modifications. So although DBT was actually originally developed at a literacy age of 12 years old, there are also modifications to bring DBT more accessibly to school environments as well as to adolescents in general.
Yeah.
So it's being used for everything and everyone. Basically.
Yes. Which, I mean, one of the listener questions that came in was, do you see it as a one size fits all approach for managing emotion? And some of what we're saying is yes and no, I guess, is kind of the answer.
I mean, my answer to that is, of course, there are going to be some people who, it doesn't fit for, they don't like the skills, or, it just doesn't resonate for them or whatever. But I think if we look at populations, when I have people ask, like, are there contraindications for DBT? My response usually is not that I know of. Like, again, when we think of psychosis, when we think of children, when we think of developmentally delayed or intellectually delayed individuals, it's really being used for everybody. Post-traumatic stress disorder is another thing that will come up with people, especially with a focus of mindfulness, as heavy as it is in DBT. Some people worry about using mindfulness with post-traumatic stress disorder, where there's flashbacks and those kinds of things. Mm-hmm. But I mean, there are ways that we learn just to do this in safe ways where we're not risking traumatizing our client, and we're working with the client and their specific symptoms and doing it safely and in ways that, again, you're doing exposure therapy, for example, to body sensations or to emotions, where gradually over time they learn to manage those emotions more effectively.
Mm-hmm. And are there myths that you typically run into that you have to try to debunk in working with these populations, or working with DBT and self-injury and things like that? Yeah.
I think not so much myths that I have to debunk with others, but that my clients tend to internalize and use to invalidate themselves with, right? So, for example, when I have clients who refer to themselves as manipulative, see, I can't even say the word because it's not part of my vocabulary. I can't stand the word manipulation. And so part of this, of course, is when somebody's self-harming, they'll say, people tell me that it's just me trying to manipulate them or trying to get attention. No, I mean, there are kernels of truth. Like, when we talk about it as attention seeking, what I try to reframe for people, I'm not going to tell that person that it's not their way. Self-harming is not their way of maybe getting a need met that's not being met. Mm-hmm. That's kind of the kernel of truth that I might find in there for them if it fits. Mm-hmm. To just label it across the board for people as attention seeking and manipulative, I think is very inaccurate and just does more injustice to the person by just, replicating that invalidating environment that probably they've grown up in and then they've internalized. So if the person does relate to, I've noticed about myself that at times I will hurt myself when I'm not getting affection that I need from my partner, for example, or my parent or whatever, then we can look at that. And first off, this is where the acceptance piece comes in. This is how you've learned to get this need met. It doesn't help us to judge it. We all, human beings, mammals in general, we learn different things in terms of being in relationships with people. We all learn the same way, and that's through learning theory, behavior theory. So I talk to my clients about, probably this behavior has been reinforced by people in your life. And so we'll look at that more closely and what that means exactly in an accepting and non-judgmental way. And so I'm helping them to learn about themselves, to be accepting of that experience, and then what are we going to do to make this different if you don't want to keep engaging in this behavior in order to get that need met?
You're listening to OTC episode 51 with Sheri Van Dijk, author of the DBT workbook, Don't Let Your Emotions Run Your Life for Teens. We'll be right back after a brief word from our sponsor.
Would you like to talk to a counselor but can't find the time? Would you rather talk to someone from the comfort of your own home? If so, Parenting and Family Solutions is here to help. We now offer teletherapy to all clients who reside in the state of Pennsylvania. Using our secure portal, you can have a video session with your counselor using a laptop, desktop computer, or smartphone. Visit our website to learn more at www.parentfamilysolutions.com or give us a call at 717-602-5560 to see if teletherapy might be a good fit for you. Let us help you build a stronger family and a healthier you.
You brought up, you kind of referenced the one that I encounter a lot is this is just attention seeking or it's manipulation. And like you said, a lot of times we all want attention. We all need attention. And, especially if you have somebody who struggles with emotional regulation and hasn't learned better coping skills. Yeah, they're going to.
They need others to soothe them.
Yeah.
Yes.
And it's sort of so pay attention to them. Exactly.
Let's give them what they need in healthy ways and help them learn healthier ways to ask for those things, right? Yeah. That's what it boils down to.
And I think, especially connected to bipolar and borderline personality disorder, I think some of the ones that I've encountered a lot, and I don't know if you can speak to this, is I think a lot it was viewed as primarily in the female population as being very prevalent. Definitely the borderline personality disorder, that myth that it's that's only a diagnosis that women deal with. Definitely on the self-injury end of things, I've seen that that myth be debunked just by nature of a lot of people are using that as a coping skill or dealing with that, or any others that you encounter.
The other myths, not really that come to mind. I mean, the manipulation one I think is one of my biggest pet peeves, and just labeling those behaviors as attention-seeking and manipulative. No, nothing else that's really coming to mind, John.
Well, one, I gotta ask, sorry, it made me think of a college professor. Are you typically using your workbook in your own practice? Or?
So I don't know if I should answer that. So I don't actually use my workbook a whole lot. So now I've also written like 6 other books at this point. I do use bits and pieces.
You got a lot of library to draw from.
I have a library to draw from, yeah. But the book that I use most often is actually Marsha Linehan's manual. Okay. I got to tell you. I admit it.
Hey, no shame. I'm sure the publishers don't want to hear that, but
I know, right?
For myself, I'm even bringing up the podcast. I try not to bring it up because I almost feel like this. It's like, you think of the college professor that you look at the book list for the class, and it's like all their own books.
Right, exactly. Yeah, no, it's funny because I talk to people like yourself who mention, I tell people about your book all the time. I have a colleague who just asked me if I could sell her some books in bulk so that she can sell them to her clients. And I'm thinking, most of my clients don't even know that I've written books.
Nice.
So, yeah. It's that I can't toot my own horn thing, I guess. But no, most of my worksheets and handouts that I give to clients, some of them do come from some of my own books, because I find that they're more generalized, because Marsha's work, of course, is specific to BPD, and sometimes it just doesn't fit with the folks that I'm working with. But most of my stuff does come from her manual. Okay.
And kind of going back to that, sort of the DBT 101, when you're first working with somebody, what are some of those foundational building blocks of emotional regulation that you're trying to teach and equip them with?
So, it depends on what they're dealing with, but I would say 9.5 times out of 10, I'm starting with mindfulness stuff. Because those, in DBT, the module where we teach mindfulness is called the core mindfulness skills. Mm-hmm. Core meaning that they really are foundational to the rest of the skills and to the treatment as a whole. So that's typically where I'm starting. But the exception to that is actually, you've asked a lot about self-harming. And so when I do have somebody who's self-harming, usually that's where, before I teach them about mindfulness, I want to teach them some crisis survival skills. So these are distress tolerance skills in the distress tolerance module. And these are the skills that help people to get through a crisis without making things worse. So without acting on suicidal or self-harming thoughts and those kinds of things. And so that helps me just make sure, as best as I can, that they're going to keep themselves safe out of the hospital and likely to be able to attend our next session, so that we can get to some of the deeper work like mindfulness and some of the, the emotion regulation skills and the interpersonal effectiveness skills. Okay. So that's really where I would start with people. The crisis survival skills essentially help people to either get their mind off of a crisis that's happening. So we talk about distracting skills, or we talk about self-soothing skills, where we help people learn to soothe themselves more effectively so that they don't have to turn to behaviors like self-harming or, substance use. Like, you could fill in the blank there with any problem behavior, but I really will focus on teaching these skills first in order to ensure safety as best as we can.
Okay. And can you give an example or two of a self-soothing or distracting? Yeah.
Sure. So distracting, and I'll give some of these examples to my clients again, because I use some of these skills myself sometimes. Even, when I get into a crisis, what can I do to distract myself right now? So I will pet my dogs or take my dogs out for a walk. That could be distracting as well as self-soothing. Mm-hmm. One of my favorite skills, though, that I teach usually in a first session with, I would say, maybe 70% of my clients, regardless of the problems they're dealing with. This is actually a new set of skills that came out in Marsha's edited book in 2014. She actually came up with a new set of skills that are skills that help us to quickly re-regulate our emotions by changing our body's physiology. Okay. And so there's a fantastic skill that's called tipping the temperature of your face with cold water. And this actually, so the directions that I give to my client is, when you feel an emotion, so it could be anger or anxiety or sadness, it typically tends to work better with the activating emotions. So anger and anxiety as two examples. When you start to feel that emotion coming on, go to the nearest sink, stick a plug in the sink and fill the sink up with water as cold as it will go. And then you tip yourself over, stick your face in the sink. I always feel the need to clarify that you're holding your breath as you do this.
Yes,
and
very important.
You keep your face in the cold water for 20 to 30 seconds. And this activates a system in our body called the mammalian dive reflex. I like giving people the background of this because they know that it's actually scientifically proven.
Yeah, that's great.
So the mammalian dive reflex changes our blood flow in our body so that our brain and our heart, I believe, get extra blood. And that helps us to quickly re-regulate our emotions. Now, the caveat with this, and I have to say this since this is going into a podcast and going out there to people that I don't know, there is a caveat to this because some people, if you do this, for example, if you have low blood pressure or if you have an eating disorder or if you are on beta blockers for heart or blood pressure problems, then if you do this skill, it can actually cause you to pass out and
make you dizzy.
Drop the stone, exactly. So you can't use this skill if you've got any of those conditions. And I tell people, if you're not sure, check with your doctor first.
Good disclaimer. Good.
Exactly. Yes. That's my CYW.
Yep.
CYA, I should say, right? Cover my ass. But this skill helps us to really quickly get re-regulated. Now, the thing here, too, though, is that it opens up a window for 5 to 15 minutes. That system stays activated.
Wow.
Where we can think a little bit more clearly. So now we have the opportunity to think about what can we do that's going to help us to manage these emotions or, to get ourselves out of this crisis situation. Is there a problem that I can solve that's going to help me cope better? And those kinds of things. But the tip skill is a fantastic skill. So I teach most of my clients that in the very first session.
Now, is that just cold water or is it the temperature that you prefer? Or
it is. So what activates the mammalian dive reflex is the combination of the cold water on your face, the tipping yourself over, and holding your breath.
Okay.
So a modification of this, some people, if you can't use cold water, so in schools, for example, the sinks often don't have plugs in them in schools, right? Or if another problem I'll run into is a female client maybe who has their hair done or their makeup is on. They don't want to stick their face in cold water, right? Which is fair enough.
Makes sense, yeah.
So the modification that we'll talk about then is they can use an ice pack instead of cold water, but still, so you want to put the ice pack over your eyes. That's the area that we're aiming for. And you still have to tip yourself over and you still have to hold your breath in order to activate that system that we need going.
Okay. And so you said it kind of gives you a 5 to 15 minute window?
Exactly. Yeah.
Okay.
So then I coach my client about, so this, you get to that wiser place for a little bit, you get to your wise mind, but it's time limited. So what are you going to do with that time? So that's when you think about, I'm going to walk the dogs in order to distract myself, or I need to go call my mom to help me re-regulate. So it just gives you a little bit of time where you can think more clearly about what comes next. How else can you help yourself?
Okay. And as just further disclaimer, partially joking, but any parents that are listening, this only works if you do this to yourself, right? This doesn't work if you throw water in your kid's face or
don't do that.
Hold their head down.
Yes. Please don't hold your kid's head underwater.
Yeah.
Although I will just add, John, it's funny you bring that up because I had a parent who was seeing me for her own emotional dysregulation problems. She has 2 kids at home, both of whom are on the spectrum and have anxiety and ADHD and other problems. And she also describes her husband as being on the spectrum. So whether he is or not is another issue. But so she was getting dysregulated at one point. She goes into the kitchen, clears out the sink takes all the dishes out of the sink, fills the sink up with cold water. The kids are standing there in the kitchen watching her do this, and they're yelling and screaming and all this chaos going on. And mom all of a sudden sticks her head in the cold water, and she's there for 15 to 30 seconds, pulls her head out of the water, and the kids are like, "Mom, what are you doing?" And this turned into a whole family event where all of them end up dipping their head in the cold water.
This is great. You try it.
Like Dad comes down and Dad sees what's going on and he has to join in the fun. So this actually turned into a great family exercise where they all got re-regulated, and it turned into quite a humorous experience, apparently. So that was also quite encouraging to hear.
Yeah. Willingly, though. They were willing participants.
Willing participants in this instance. Yes.
Nice. And you bring up a good point, too, of so often you're not, especially if you're working with an older teen, you're not just working with the teen. You're working with the parents and trying to teach them and psychoeducate them about these skills and how to help the child at home or things like that. Would you agree?
Yes, absolutely.
Other building blocks to focus on as you're, kind of the mindfulness, you were saying that's sort of the starting point. Are there others that you go to from there?
So, I mean, if the teen is still at home, or even, I have some older, not even teens anymore, but I still think of them as teens because they're, below that 25-year-old age where their brains aren't fully developed still. So when I have teens who are still living at home and there is invalidation happening in the environment, I do like to bring families in and do some skills teaching together. Because then what I can do is I'll teach. So one of the theories, we haven't actually talked about this, but I'll teach what we call the biosocial theory, which is the DBT perspective on why emotion dysregulation develops for most people. And it's the combination of I'll just use child in my language here. So it's the combination of the child's temperament, which involves being more highly sensitive or being really emotionally vulnerable is how we refer to that. The combination of that emotional vulnerability or high sensitivity with an environment where they are regularly being invalidated. Now, this is not the environment's fault, usually, for the most part. My caveat to that, if there is abuse happening, I don't think of that as there not being fault to put somewhere. That's a whole other conversation we could have. So I'm not going to go there.
A different level.
Exactly. But I just like to be clear that usually we're not putting blame on the family, because this can be something as benign as a family or a child who just doesn't fit very well with their family. So, for example, if you have a highly sensitive child growing up in a family where the rest of the family is not highly sensitive, it can be really difficult for the non-highly sensitive family members to understand the highly sensitive child's experience. Mm-hmm. So they're kind of looking at this kiddo going, why is this such a problem? Like, how do we help? We don't understand why you're reacting like this. So from the family's perspective, they're trying to be supportive and understanding, but what the child is probably hearing or perceiving is, wow, there's something so wrong with me that my own family can't even understand and help.
Wow.
So I love that example because it really takes the blame out of the equation, right? Mm-hmm. It's not the family's fault or the environment's fault. It's also not the child's fault that they have been born with this high sensitivity for whatever reason. There are some theories about, how that comes about, but again, kind of beyond the scope of this podcast. But it's a temperamental thing, right? So we can't blame the child for being highly sensitive, and we can't blame the environment for, not being able to understand and provide exactly what the child needs.
Well, and I guess as you were talking about it, what I was thinking is, one, just building off of the concept of mindfulness of like, it's not good, it's not bad. You don't have to label it. You don't it just is.
Yes.
The emotional dysregulation is there. You
Exactly.
don't have to focus on blaming anyone.
Exactly.
And yeah, that concept of you wouldn't blame a cancer patient for getting cancer. You wouldn't blame somebody for getting, leukemia. And we do that so often, especially with emotional dysregulation.
Exactly. Yeah. And so here's where, when I have a teen who's still living in that environment, bringing the family in, where I can help everybody understand the dynamic that's kind of developed over time here. I'm not blaming the family and I'm not blaming the client. And you guys need to work on, for example, validating one another so that we can help reduce the emotion dysregulation that's happening at home, both in my client, the teen, as well as in the family, because of course it can be very dysregulating to have this, emotional chaos happening in your own home, where then you have to deal with that emotional fallout as well. And that can be dysregulating for parents, for other siblings in the home, and so on. Mm-hmm. So I try to help people learn to validate each other, be more accepting of one another's experiences, and then potentially other skills might come into play there as well, like the tip skill. Yeah. And when I've taught, or the other thing that I might do is ask my client to share some of the skills that we're doing in session with his or her family. And then they kind of practice skills together as family. Family can then sometimes coach the client to use skills when they're getting dysregulated.
Yes, making the pupil the teacher. Yeah. Team
effort. Yeah, exactly.
Yeah, I can see where that would be very empowering for them.
For sure.
And that kind of starts to answer one of the other listener questions that I had is how can therapists help parents understand and respond to teens who have explosive emotions, and engage in self-harm. So having the family as part of the treatment, having them in to teach them and explain some of this and try to normalize it. Other things that you would recommend for a therapist
Yeah, so for therapists, one big thing for us in terms of DBT is modeling for our clients how to use skills. And so this is where, again, I share stories with my clients about how I've used skills. I use skills in session myself. So one thing my clients will tell you when I start, I'm going to digress for a second here. Another one of my favorite re-regulating skills is a skill that I discovered. It's not a DBT skill. I call it the forward bend. And it's similar to the tip skill, but it doesn't involve the cold water. So if you do yoga, the forward bend, it's essentially where you just are bending over trying to touch your toes. Mm-hmm. And so I discovered myself when I was dysregulated one day walking into yoga class, I did a forward bend. And when I stood up, my emotion was completely gone. And we're talking like going from almost being in tears to 30 seconds later, feeling totally okay.
Huh. Wow.
That's right. That was my response. So that afternoon, actually, that might not have gone anywhere, but that afternoon I had a client come in who was really dysregulated. And I said, would you mind trying this with me? Because this is what I told her the story. This is what happened this morning. Give this a try with me. So we both stood up and did a forward bend together. And it was the same thing. It was, that really worked.
Yeah.
So then I teach the forward bend to everybody. And I will actually model for my clients. If I get dysregulated in session, so usually it's because my client is really dysregulated and I'm struggling to get them re-regulated. If, I'm going to throw out some words here that not everybody might understand, but if willfulness is happening in my client and they're not willing to engage with me in using skills to try and get them re-regulated, sometimes, I don't do this with many of my clients, but I do have a couple of clients where I'm comfortable saying, you know what, I'm feeling really dysregulated right now, so you can stay sitting there if you want, but I need to do a forward bend right now. So I'll actually just get up in session and do a forward bend to help myself get re-regulated. Now, by the way, usually when I do that, they end up standing up and doing a forward bend with me.
Okay.
So it's also a nice way of getting them to be more willing to work with me again. But at the very least, I've just re-regulated myself. Mm-hmm. I've given myself a little bit of time to think more clearly, and then I might be able to come back and say, okay, here's something that's occurred to me. Let's give this a try.
Yeah, it made me think of they talk in parenting about connect and redirect, and obviously that's all redirect, no connect.
Right.
But that idea of just this sharp kind of 180 of like getting out of, whatever it is you're feeling or thinking and doing something else that really kind of jogs you out of that.
Exactly.
Nice. Okay.
So my point here was I model for my clients. And so as therapists, we need to be modeling these skills, not as best as we can, not being distracted by phones and other stuff in session. Like not another one that is a pet peeve for me is when I see colleagues being, 10 minutes late for session with clients. If you don't want your client to be late, then you can't be late.
Yes.
Right. And no, sometimes there are crises that are beyond.
Yeah.
Right. Absolutely.
But like chronically. Yeah.
Not chronically. So just modeling for our clients, and then also talking to families about how they can be modeling for the child, for the teen, the skills, the skillful behaviors that are going to help them to manage their emotions more effectively.
Nice. Yeah. I definitely, that concept of where does the emotional dysregulation come from? I'll tease that for having you on another time, because that's one that, I think we could have a whole week's worth out of just that one as well. Are there other things that you would advise, parents or loved ones if they have somebody that struggles with emotional regulation, of ways to help or things that they can do? Yeah.
Well, one thing that I do talk to the parents that I'm working with, or the caregivers, is, again, working on managing their own emotions, because this can really cause burnout in caregivers, right? So taking good care of themselves is going to help them be more accessible to continue to help their loved one. Again, it's also modeling good, self-care and skills use for their loved one. And aside from that, really what I typically always come back to is validating. So validating the person with the emotion dysregulation problems, but also self-validation, where we're accepting our own emotional responses, which, is of course part of that self-care package as well. Yeah.
And it's interesting because I'm trained in Gottman counseling, and I work with a lot of couples, and the stress-reducing conversation is an exercise that I teach to almost everybody.
Nice.
And that concept of like hearing the emotions, validating them, supporting them. Yeah. We just as a species, I feel like we don't do that very well. Most people don't naturally gravitate to that. They do the opposite, where either they try to shut it down or they try to problem solve it. And that actually has the opposite effect.
Yeah, problem solving still feels like shutting it down, right? I can't tolerate your emotion, so here, let me fix it for you.
Which then, like we were saying earlier, prolongs the issue, because now I haven't validated your emotion, I haven't supported you, and I also haven't modeled to you as a parent, how to do that for yourself.
Right, exactly. So. And to validate the parents, by the way, it's very understandable.
Oh, yes.
You don't want to see your child suffering, right?
Yeah.
So it's understandable, and it's not typically that helpful in the long run.
More so when, kids are younger, you can get away with more problem solving. You have to, as the parent when you have an infant or something like that. But as they get older, it's that transition of like, okay, let me teach you how to do some of this and teach some of the emotional regulation and things like that. So, wow. So I know you mentioned in our communication, are you currently working on another book, or that is, projected out there? Or,
so I'm in the middle. So I've got a final deadline coming up in May. This is book number 8. No, I'm doing okay for that.
Okay.
And this is book number 8 that I'm writing with New Harbinger Publications. It's going to be coming out in January of next year. And it is actually the DBT skills workbook for self-harm for teens.
Wow. Okay.
So it's a heavy one, but
that's the working title?
No, that's actually the full title. That's the final title.
Nice.
Yeah, so it'll be a workbook geared towards teens. So teens for my publisher is typically like 12 to 19, I believe, is the age range that they gear it towards.
Okay.
I don't really keep their age range in mind because I essentially just write about the conversations that I have with my clients. So to me, it's I'm always speaking to my clients as though they're, adults, and they're, they've got lots of skills and lots of, resilience to draw on, and that we are working on bringing out. So I kind of treat my clients as though they're adults, even if they're 16 years old.
Yes.
And so this workbook, though, is geared towards the self-harming behaviors specifically, although it's a workbook that can be generalized. So if it's not self-harm in the way we're defining it for this workbook is like doing actual tissue damage, harm to yourself, so cutting and burning and those kinds of things. If your teen isn't doing that, but they're doing things like substance abuse or disordered eating behaviors and those kinds of things, the skills can still be generalized to those other kinds of problem behaviors as well. So it's a nice generalizable or specific to self-harming kind of workbook.
And off of that, are there any, sort of brief tips? Again, probably have like a week's worth of podcast episodes off of the self-harm topic as well. I think for so many parents, it really scares them. They're just not used to it.
For sure.
What advice would you give a parent? Oh, yeah. Therapists too, sure.
Right. Yeah, and it is a scary thing. So what advice would I give to parents?
Yeah, any quick tips or, how do you, how would a parent deal with this if they just discovered, okay, my kid is cutting themselves or burning themselves?
Yeah. So I think, one of the most important things is, again, acceptance. So not that you like, of course, that this is happening and not that you're going to be okay with it continuing to go on, but not judging your kiddo for the behavior that's happening, being curious about it. What's going on? So opening the door to conversation that can be very healthy and may actually have been what the child was needing, just an open line of communication, and they didn't know how to get that. Mm-hmm. So that would be one huge thing, offering therapy if the child or teen isn't, open to talking to parents, which is often the case as well, making sure that they're forced into therapy, but that they have the option of attending, with somebody that is more objective, that doesn't have the same kind of emotional responses that parents are typically going to have to their behaviors and so on. Mm. And also that might not be a therapist, that could be an aunt or an uncle that they're more comfortable with, or, anybody. And then lots of self-care and skills use and skills modeling for the child and validation. I mean, kind of all of the things that we've been talking about already, not blaming themselves for what's happening, but, being realistic and eyes open about it. And also, I think this is a struggle for people. And of course, this takes some work, but finding a balance between being punitive and still sticking with consequences when there are behaviors that come up, like problem behaviors like cutting, because some parents will really get afraid that, if I punish my teen for coming home late, then they're going to cut or, whatever, right? So making sure that, because you can't then start walking on eggshells and not have any consequences, because then you're going too far in the other direction of not having enough structure for the teen. And they need structure. They need limits and rules in order to help them feel safe and feel secure, even if they don't like it. Liking it is a different thing from needing it, right?
Yes.
So go ahead.
Can you say a little bit more about that? Because, I'm really having to fight back the desire to go Joe Rogan on everybody and be like, all right, strap in. We're going for a 3-hour podcast episode. But that's such an important thing there. Now, you're not saying punishing the child for the self-injury. Exactly. I want to clarify that, correct?
Yes, exactly. Thank you.
Yeah.
No, I'm not saying validating, there's clearly a reason that they're turning to this behavior. So validating even not the behavior, but the reason behind it, if you know what it is, wow, you're so sad and you didn't know how else to express the sadness. And so this is why you're turning to cutting, if that's what you know is going on, right? Mm-hmm. So validating the emotion or the thoughts, behind the behavior, but then still setting healthy limits for them. So I find that often what happens is parents do get afraid that, well, if I set limits, then it's almost like they feel like they're being held hostage.
Yeah.
No matter what I do, if I do something that my child doesn't like or set a limit that they don't like, then they can always cut, and they know that freaks me out. And so I'll give in to that.
Yeah.
But the idea here is then that's what you're teaching the child, right? Remember that learning theory that I talked about earlier.
Yeah, it's sort of the symbiotic conditioning.
Exactly. So we need to still have limits, and there still has to be consequences. And then you stick to those consequences, even when your fear is really high that, they might do something. Now, if you're fearful for their safety, there are things you can do, right? You take them to the hospital. Maybe you do actually take them to a therapist, even if they don't want to go. That would be a natural consequence of the choices that they're making. Mm-hmm. Which is still teaching them that, there are going to be consequences. So no, it's not punishment. I'm not punishing you by taking you to the therapist, although that's sometimes
gets perceived that way. Yes.
But if this is what you're going to do to yourself, then it is just a natural consequence that you're going to have to talk to somebody about it, or that you're going to have to go to hospital to get medical attention for it, or whatever. Well,
yeah. And that the difference in perceptions over me loving you and you feeling like I'm punishing you.
Yes. Yeah. And then again, sometimes that comes back to our tolerating, or the parents tolerating that their child might be angry, tolerating the fear that, yes, they might hurt themselves or engage in some other kind of problem behavior, right? So, we also have to learn to tolerate that fear, because we can't control, even though it's a teen, they're still living in our house and we have our rules, we can't control their behavior is what it comes down to, right? Well,
and the more you try, the worse it's typically going to get.
Sure.
So now, in terms of exploring emergency services and hospitalization and things like that, I know a lot of therapists go a lot of different directions with the self-injury, and at what point do you go to the ER or look at getting inpatient hospitalization or things like that? And I don't know if you give any guidance on that, or
this really is an individual thing. So the DBT kind of general rule is that there is no evidence that hospitalization actually helps clients with borderline personality disorder. So again, because they're still very focused on treating BPD, that's the general rule there. That doesn't mean that you never do it, right?
Thank you.
But generally, it's actually not helpful typically. And some of the reasons for that would be, reinforcing problem behaviors. So if the person is having talking about suicide, for example, and so they go to hospital, maybe they're getting a lot of validation at the hospital. So potentially their behaviors are being reinforced by the care that they're getting at the hospital. Mm-hmm. So we want them, again, to get those needs met in healthier ways and their life outside of the hospital.
Well, and I had the pleasure of talking with Dr. Jonathan Singer. He talked about, hospitalization. It's designed to keep you alive. It's designed to stabilize you. That is really what it is there for.
Exactly.
It's not going to really, really treat the symptoms, and you're going back to your life, which is typically where all the stressors and the emotional dysregulation occur. So,
Exactly.
Okay.
So, and that's kind of the guideline I give my clients. Like, our last resort is hospital. So if you feel like you can't keep yourself safe, then yes, absolutely take yourself to hospital. Mm-hmm. Because if you're not alive, then I can't help you.
Yep.
Right? So I want you to be able to attend our next appointment so I can help you get your life, back to a place that's worth living. But it is last resort. And I'll talk to my clients if they've had hospitalization experiences. We talk about that. What was it like? Was it validating? Some clients don't ever want to go back to hospital because it was such an awful experience.
Yeah.
In which case, then I need to, again, find the more balanced perspective of, okay, it is last resort. And if you can't keep yourself safe, we do need you to go, right? But let's also just clarify too, though, that typically people, when they're self-harming, they're there is a difference between self-harm and suicide, right? So,
yes.
A lot of people, if they're just self-harming, it has nothing to do with wanting to kill themselves. I've had clients tell me that they self-harm in order to prevent themselves from making a suicide attempt. Mm-hmm. So it's important that we be clear around what the intention is. And if it is self-harm to the point where they need medical attention, then yes, they still go to Emerge to get medical attention, mm-hmm. but not with the intention of being hospitalized.
I think going back to your point, in the family having those conversations, being
yes.
able to talk about, what are you feeling? What are you thinking?
Right.
Are you saying you want to actually be dead, or
yes.
this is a way that you deal with, the emotional or the physical anguish or trauma, and mm-hmm. this is how you express that pain.
Yeah.
I guess I would, the question I want to ask is, a lot of times I'll talk with parents about, don't just clamp down on the self-injury, the means of self-injury. Like, you can't just rip away, like, fine, we're taking away all the sharp objects
right.
Today. I usually describe it as this, like, slow replacement behavior, mm-hmm. As opposed to, like, a really quick, sharp, we're taking this away and restricting your access mm-hmm. to it. Does that...
I think for me, it depends on what the instrument is. Like, if it's... a lot of my teen female clients, for example, I'll cut in the shower with my razor.
Yes.
So I don't see any reason for the razor then to stay in the bathroom. And for
okay. me,
it's also partly if we eliminate the means, or like reduce the means, at least reduce access to the means, then it's less temptation, right? Mm-hmm. If it's sitting right there in the shower, when you happen to feel a little bit emotional, you're going to be more likely to engage in the behavior because it's handy.
Yep.
So, I think it's, though, also taking a more balanced approach where, no, the razor blades don't have to live in the bathroom, but do you need knives in the kitchen? Well, of course you do, right?
Yes.
So, no, I don't usually talk to my clients about getting rid of every sharp instrument in the house. But typically, the people that I work with have a particular, it's almost like a ritual that they engage in. Preferred method. So that's where we want to either eliminate or at least reduce the means to those instruments.
Mm-hmm. And again, going back, the repetition of, especially if it's a parent or a loved one, like having that conversation with the person
yes.
about that, like, how do we make this safer for all of us, or,
for sure. And again, doing it in a validating way, we get this is the means that you've been using to manage the emotions. Yeah. But we need you to start using skillful behaviors. And usually there's agreement from the teen, by the way. If the teen is my client, for example, they're the ones telling me, I cut with the razor blade. And so my first response is, okay, can you take the razors out of the bathroom? Mm-hmm. And then I'm getting agreement from the client. I'm getting commitment. Okay, do we need to are you going to tell your parent right after our session so that it makes it more likely you do this? So we plan it. It's very collaborative so that mm-hmm. I'm going to get more likelihood of follow through, right?
Sure.
And again, it doesn't feel punitive. It's collaborative.
Great. Oh. Well, Sheri, I know we have to wrap up here. Where can people find you if people want to book you for speaking engagements or trainings? Yeah, where can they get in touch?
Yeah. So I have a website. It's SheriVanDijk.com. So if you Google me, you'll find me and my multiple books. And I love doing trainings. I love doing podcasts. So, John, if you want to get in touch again, I'd love to chat with you again some other time.
Oh, definitely. Yeah.
But SheriVanDijk.com is my website.
And that's the DIJK, correct?
That's right. Yes.
Yep. And I always have the show notes and links and everything, so people will be able to get there through the pfsonthecouch.com stuff. So, I'm really looking forward to your next book, and
so am I.
Referring that to being done with it, you mean? Yes. But thank you so much for being able to come on. For any therapists out there that are listening, I would say, like you were saying, it's, I wouldn't say a barren landscape, but there are not as much as we need in terms of the DBT space. And some of that is because of some of the clients and the symptoms that you have to deal with on a regular basis, but we need more. So somebody out there within the sound of my voice has a heart for these types of struggles and people, and we need more people trained in this. So please do that. Is that a good PSA for?
That is awesome. I love it.
All right. Well, thank you so much again. Take care.
Thanks, John.
All right, OTC listeners, that wraps up another episode. I will join you again in a few weeks for episode 52. And so the way this is going to go is similar to season 1. We're going to go right up until December. So last episode will be at the end of November, I believe. And then during December, I'm going to take a break to spend time with family and just enjoy the holidays. And then I'll join back up with y'all in 2021. Let's see what 2021 has in store for us with season 3, and already have a number of episodes recorded. A lot of great conversations that I've been privileged to have. So I'm looking forward to bringing that to y'all. But I will catch you all in episode 52. Take care. Well, if you liked what you heard, be sure to subscribe, rate, and review wherever you're catching this podcast. You can check out detailed show notes and any other resources given in the show at www.pfsonthecouch.com. If you'd like to stay up to date on upcoming episodes, guests, or contribute questions to the show, be sure to follow along on any of your favorite social media platforms. The author and host of this podcast is not engaged in a therapeutic relationship with the listener and cannot give counseling advice without a confidential appointment. Listeners should be sure to consult with a licensed therapist in their area or seek emergency medical attention if they are experiencing psychological difficulty. A special thanks to the band The Topsy-Turvies for the show theme song. Their song, Like a Living Dead, can be found at topsyturvies.bandcamp.com. The bump interview track was the song 1973 by Bruno E. The author and host of this podcast is John Dennis. Special thanks to show editor Casey Lehman and show producer Trevor Groff.